Brain Chat. I'm Dr. Mitzi Joy Williams, your board-certified neurologist and fellowship-trained multiple sclerosis specialist. My mission is to engage, educate, and empower those impacted by chronic neurologic conditions to become an active part of their healthcare team. Here on Brain Chat, we'll be discussing all things brain health, wellness, self-advocacy, and how to care for your loved ones who are impacted by chronic neurologic conditions. Join me and my super friends and special guests as we get ready for the next episode. And most importantly, let's get nerdy. Hello, friends. Welcome to Brain Chat. It is Dr. Mitzi, the nerdy neurologist, and I am so excited to be here with you for another episode. And listen, we are talking headaches today, and I have got an expert for you. If you have never logged on to Brain Chat or watched us, if you're watching live, just type in the chat and let us know where you're logging in from. I bid you greetings from Atlanta, Georgia. And I'm so excited about the guest that we're having on tonight. So Dr. Hope O'Brien is not new to Brain Chat, but she's been with us before, and we're so excited about her coming back and lending us her expertise to talk about headaches and facial pain. So she is the founding medical director of Headache Center of Hope, and she is also volunteer faculty at the University of Cincinnati College of Medicine. Welcome back to Brain Chat, Dr. O'Brien. How are you?
Dr. Williams, hello. Thank you so much for having me here again. I'm so excited to see you and to talk to you and talk to your guests.
Awesome. So listen, headaches are a really common problem. And I know we've talked about this topic before, but listen, we can never educate people enough about headaches. I cannot tell you how many consults I get about headaches, and I'm sure you have a headache center. So that's your specialty. But headaches are just such a common problem. And sometimes it's hard to know what is within the realm of normal. When should we be worried? When should we take treatment? When is the treatment not working? When is the treatment making it worse? So just a lot of things to talk about, a lot of things to kind of sort out. But before we get into that, we would love to hear, even though you've been with us before, I love to hear everybody's neurology origin story. So tell us what got you interested in neurology and what got you interested in working with those who have headaches?
Well, as a schoolgirl, I had a strong interest in science. And so one of my teachers, my science teacher, recommended that I go on a field trip to visit a college when I was living in Florida. So I went with a few of my classmates to the University of Florida, and we visited a lab. And in that lab was a jar, and in that jar was a clear fluid that contained a sheep's brain. And I thought to myself, oh my goodness, this is a real live brain. I've never seen one before. I was so fascinated by how this organ controls everything we do, everything we are, how we think, how we feel, how we function. And from that time forward, I thought to myself, I want to study this. I want to become a physician who studies the brain. And
I love it. I love it. What an amazing story. Now, how old were you when you saw that brain?
That was about 16 years old. So
Okay.
It was PG-13 above.
Okay. I always think back to this time. I went to one of my kids' elementary schools, and they have the doctor come, parent day or what have you. And so I was giving a lecture with one of my friends, and we were in this auditorium, and I showed a picture of, it wasn't even a real brain. It was like blue with sparkles. And I remember I put up this slide with a picture of this, blue sparkly brain, and literally 50 kids in the auditorium were like, ew. So I just have that stuck in my mind, like, okay, well, maybe I won't show brains. But apparently, if they're a little bit more mature, you can be inspired by a picture of a brain or an actual brain. So that's really cool. Really cool. All right. So let's get into these headaches. All right. Migraines are some of the common headaches that people have, but I have lots of people who come in with headaches. So let's start off with migraine, right? Because everybody has heard of migraines. So let's start off with migraine. What are some of the characteristics of that type of headache? And how would someone know, let's say, that they're just having like a run-of-the-mill or when should, or I guess the real question I want to ask is, when should you be concerned about getting headaches treated, right? All of us have
Mhm.
a headache every once in a while if we are real tired, etc. But when should you be concerned about getting a headache treated?
Well, I get asked this question all the time, and you can imagine because people just assume, oh, it's just a simple headache, pop a pill, it'll go away.
Mm-hmm.
And so when I talk to patients, I say, well, headache is a symptom. Just
Mm,
like having a belly ache or having a scratchy throat, it doesn't tell you what the cause of that is. Headache is just one symptom of a condition. And so, migraine is a complex neurological disease that is composed of headache and other symptoms as
mm,
well. So patients will complain of moderate to severe pain intensity, typically lasting anywhere between 4 hours to as long as 72 hours, so three
mm,
days. The pain tends to be either pulsating or throbbing, typically unilateral or one sided, but it can involve both sides of the head. The headache is also associated with nausea or vomiting or light and sound sensitivity. So we call the light sensitivity photophobia and the sound sensitivity phonophobia. So that with a family history of migraine and the fact that these episodes have occurred 5 times in a lifetime gives you the diagnosis of migraine.
mm. So 5 times in a lifetime. Let's talk about kind of the age range, right? I have some folks who have never been diagnosed with migraine. They said, I've had headaches since I was a teenager. What is the age range that people usually start to have migraine headaches?
Well, I actually did a fellowship on kids with headache. In other words, not only did I study adults with headaches, but in particular kids. And so kids can get migraine as young as 18 months old, even younger. So
Mm,
10% of school age kids do have migraine. Unfortunately, it's underdiagnosed and
mm,
undertreated in that age group. And
mhm,
typically, boys tend to start getting headaches around the age of 6.
mm,
Okay, 6 or 7. Girls start to get headaches a few years prior to menses, so a little
mm,
bit older. And as an individual develops, what happens is that the prevalence of migraine, instead of it being equal in boys and girls, that girls start to continue with that higher prevalence as they develop.
mm. Wow, as early as 6. Wow.
Mhm.
Um, it's really interesting because I have folks, who develop headaches in their 20s or in their 30s, and they're like, "What do you mean I have migraines? I've not had headaches before," and so I think it's important to recognize that they can start early, but in some people they can start a little bit later. I think the key is, if you have those symptoms or if you're having a recurrent headache, you need to get checked out by your doctor, preferably by a neurologist. And if they live near you, by a neurologist that specializes in headache. So, how common is headache, right? So, does everybody in their lifetime have a headache, or how common is headache just in general?
So, headache is common. The diagnosis of migraine is particularly common. 39 million people in the US are affected by
Did you say
migraine.
billion?
Million. 39
Million. Okay.
million, 1 billion worldwide.
Mm,
So it's very common. The most common type of headache, though, is tension type headache. So
mm,
more people have tension type headache, which is a more milder type of headache. Tension type headache is not associated with those with the nausea typically, and so they may not have a severe headache, and so that would be more along the lines of tension type headache, and it's more of a band-like headache. Where we worry that the headache is becoming a problem is if it becomes more and more frequent to the
mm,
point that you're using over the counter medication more than 3 days a week.
mm,
If you're starting to not respond to medication, that's worrisome. If you start to get numbness or tingling that's lasting a long time, or something that's new or unusual, some of that numbness or tingling can be aura. But if that lasts longer than, let's say, an hour, that's a problem. If you start to notice weakness or loss of vision, that is atypical of what we call migraine aura, meaning it doesn't go away, or if it's a new sign that you didn't used to have with a headache, we want to make sure that we get that checked out. And the other
Mhm.
thing I want to say is, I had a patient who I saw who had mentioned that it was actually a 10-year-old patient, and the mom had mentioned that they took her to her pediatrician, and her pediatrician had mentioned, oh, we don't diagnose migraine in kids. And the reality is, as long as they meet that criteria for migraine, we can
Mhm.
absolutely make that diagnosis.
Mm. So tension type headaches are the most common, and then migraines, certainly are more severe or more
Right, more
intense, oftentimes
debilitating.
in tension, more
Hmm.
debilitating than tension headaches. So
Hmm.
let's talk about these headaches that we heard about growing up. A hungry headache, a sinus headache. What are those headaches? So my mom's like, "Oh, you just got a hungry headache." Or,
Hmm.
everybody's like, "I had a headache, but I thought it was sinuses, so I just started, and it's a sinus headache." What are those headaches?
So, if I were to guess, those headaches are probably migraine. And as I mentioned before, migraine is underdiagnosed. And the thought is that so many people have it that it's just like, and they notice that, oh, if they miss a meal or if they are tired or have lost sleep, that they'll develop these headaches and
Mhm.
not realizing that these are migraine. And as
Mm,
long as they go away and they're not really impacting your day to day, and it goes away either with treatment or even without treatment, not a problem. I
mhm,
see patients when it starts to impact their work or their ability to function. So those
mhm.
hunger headaches are most likely migraine.
And so I remember one of my professors when I was in residency would say, "Every headache is a migraine until proven
Yeah.
otherwise." So I think, but I think that that's important for people to know. Again, it doesn't mean everyone needs to rush out and go,
Correct.
get on 50 different medications,
Correct.
but, those headaches that we're calling these other names could be, migraine headaches. And if those are getting worse, or they're not controlled with the things you used to do, like take your sinus medicine or, et cetera, then it's
Mhm.
a reason to consider getting evaluated, because you could very well have migraines and just never
Abs-
had it formally diagnosed. So let's talk
Absolutely.
about lifestyle, right? So I'm
Mhm.
really big into lifestyle modification. Of course, we know that there are medications, and we'll get into those in a minute. But let's think about some of those triggers. What are some of those triggers that can make headaches come on for someone who has chronic headaches, whether they're tension headaches or migraines? What are some of those things that can trigger
Yeah.
those headaches to come on that people need to be aware of, and paying attention to?
So one of the things that patients with migraine is sensitive to is dehydration. So
Mm,
they may notice, like in the summertime, they may have more headaches, or if they're exercising or doing some strenuous activity for a long time and they're sweating and they're hot, that they may have a headache. And part of that is because they've lost fluid,
mm,
salt and water. So they really need to hydrate themselves, prior to and, throughout the day if they're doing a lot of exercise or strenuous activity. So dehydration is the key. Try not to get dehydrated, stay hydrated. The other thing
mhm,
is sleep. So making sure that you're getting regular sleep, not going to bed too late or waking up too early and you're off schedule. The brain likes regularity. So if you go to bed around 10:30, 11, keep that schedule. If you're waking up at 7 a.m., I wouldn't go past, an hour, because the brain doesn't like change. And then the other thing is caffeine. My patients cry when I tell them, what, I think caffeine may be contributing to your migraine. And they're like, wait, what are you talking about? Caffeine is one of the treatment for migraine. It's actually one of the medicines that I got over the counter. And
mhm,
truth behold is that caffeine, if you're drinking too much of it, can actually make the brain more susceptible to getting migraine.
mm,
We call caffeine is what we call a diuretic. You pee out whatever hydrating fluid you're intaking, and then it also makes the blood vessels go into vasospasm. So
mm.
not to say that migraine is caused by the fact that the vascular system is going closing and opening. It's part of it, but what I tell patients is, let's try to minimize the likelihood of these potential triggers causing migraine.
Mm. So speaking of, walking that fine line between too much of a I won't necessarily say a good thing. I mean, caffeine can definitely be a good thing when you need it.
Yeah, 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 yeah,
But speaking of
absolutely.
that, we see something similar with, let's talk about medication overuse headaches. So I have some folks that say, I had a headache and then I started taking goody powders and I started taking them 2, 3 times a day. And now every day I have a headache. Tell us a little bit about how that happens and how we potentially get rid of that medication overuse
Yeah.
headache.
So, there's still some controversy about whether or not taking too much medication can lead to more debilitating or more frequent headaches. But what we've learned in our patient population of those who have migraine is that if you overuse, meaning if you're taking an over the counter medication too frequently, and that number right now is about 3 times per week
Mm,
or 12 times per month, then
mhm,
you are at risk for developing medication overuse. So that means that instead of stopping the migraine, it stops it or may relieve the pain temporarily, but then the headache always comes back. So we call that rebound. Okay.
mm,
That can also happen with combination over the counter medication. So the medication that contains acetaminophen, ibuprofen, and caffeine. If you use that more than 2 days a week, then you're at
mm,
risk for developing medication overuse. And then lastly, migraine specific medications can lead to overuse as well. So if you're taking too much triptans, like sumatriptan,
mm,
you can overuse that. And what happens is that the brain becomes what we call desensitized, meaning that now the brain stops responding to what typically would stop a
mm,
migraine. So the
mm.
way we reverse that or treat that is by stopping those agents and then letting the brain sort of heal so that it can start to respond to those agents.
Mm. So let's talk about a little bit, let's park a little bit here with treatment. So when we think about treating headaches, depending on how frequent they are, sometimes people will need a prophylactic medication. Tell us a little bit about those types of, we don't have to use, specific names, but those types of medications and what they're for. Because sometimes I have patients who come in and they say, well, my doctor gave me this antidepressant and told me to take it for my acute migraine. And I'm like, well, that's not how that works. Um, let's revisit. So tell us about kind of the classes of medications we use and what those medications are supposed to do.
Yeah, so preventive or prophylactic medications are medications that you would take every day, or in now the newer cases, every other day, or now once a month, or now
Once a month.
once every 3 months. So these are medications that are there to decrease the frequency and severity of migraine symptoms. So if somebody is having, let's say, 15 headache days per month, the goal is to reduce that number of headache days or the disability that those headaches have by at least
Mhm.
half.
By
And
at
the way
least
we
half.
do that is by starting a medication that will alter the chemicals or neurotransmitters involved in migraine so that patients can get relief. So the different
Mhm.
classes include beta blockers or your blood pressure medications. There are anti-seizure medications that are used as well. There are antidepressants. Again, we're not prescribing them for depression or for blood pressure necessarily, but they've been studied in research to help reduce migraine symptoms. That being said, what other disease process do you take a different medication for that disease? In other words, I would not give somebody a medication, let's say, for diabetes if they didn't have diabetes, but yet we do that in migraine. So more recently, migraine specific medications have come out that actually
Mhm.
target the key neurotransmitter involved in migraine so that not only do we have tools in our toolboxes or treatment that can be taken orally, but we also now have treatment that can be injected once a month or
Mhm.
once every 3 months. We also
Yeah,
have
and I
devices.
yeah, and I think, it's been amazing to see these breakthroughs. I am dating myself a little bit, but these drugs did not exist when I first started practicing. So it's been really cool to see, specific treatments for migraine. However, unfortunately, there's this little thing called insurance. And even though we have these great drugs that are specific, sometimes they still want us to use these other
Oh,
medications that are older and much cheaper, and may have more side effects, frankly. And so, I think that it's important, as you said, for people to know that, in the field of headache and in the field of neurology, there are many medications from different classes that we use for different things. So I tell people, listen, now when
yeah.
you look it up, it's going to say it's an antidepressant. That's not why I'm giving it to you. I'm not trying to be slick or give
Hmm.
you anything on the sly, but studies have found that this really does help with your condition, and so I think it's been really amazing, to see kind of the change in how we treat migraine and the improved quality of life for so many people. Some people have to stop working because their headaches are that severe. So I think that this is it's been really amazing to see, this change over time. Uh,
Absolutely, Dr. Williams. And I will tell you, for some patients, those medicine may be very effective, especially if they do have some mood issues or if they do have seizures. Um,
mhm.
but again, it doesn't work for everybody.
Yeah. And so before we go over into facial pain, one more thing about headache. I'm always big on patient advocacy. And so I always
Yes.
think it's important for people to know, number one, what are things that I should be looking for that will send me to the doctor? Now, of course, we do not give medical advice on brain chat. You should
Yes.
always consult your neurologist or your PCP. But sometimes there are red flags that people should not ignore when they're having headaches, meaning do not pass go, you need to be seen. What are some of those red flags that make us say, you need, hey, don't wait this one out. Go get checked out.
Absolutely. And advocacy is so important. I try to do that each and every day when I talk to insurance companies or,
Hmm.
talk to my government officials about advocacy
Yeah.
for migraine because that's just not enough treatment options. But in terms of the symptoms of that are unusual that don't necessarily occur with migraine, one thing I tell patients to stop and go straight to the ER for is that sudden onset of worst headache of your life.
Mm-hmm.
Even if you've had migraine, if you all of a sudden have a worse headache of your entire life, that's very different than your typical migraine. That's important
Mm-hmm.
that you get checked out.
Yeah.
Other signs are concerns for stroke. So typically, strokes don't cause headache, believe it or not. But if you do have a headache and you have numbness or weakness or loss of vision or clumsiness and not able to walk or balance issues, definitely get worked up. If
Mm-hmm.
you have a fever associated with headache, very
Mm-hmm.
important. So, fever or mental status changes, meaning you have problems thinking or concentrating, or you're not able to remember things, you need to get checked out.
Mm-hmm. So such important information. And one more thing that makes me think about it is that I think it's also very important for people to, you don't want to think about your headaches when you're having pain, but when you go to see the doctor, there are some key things that we're going to ask, and it would be really helpful if you thought about those things before you come to see us.
Yes.
Like, okay, where does it hurt
Hmm.
typically, right? Is it on one side? Is it both sides? Do you have any of those associated neurologic symptoms like vision problems or something like that? Do you have any warning or aura before your headache comes on? How long does it last, right? Because it can be very difficult and frustrating for the patient, the person, the individual who's trying to get help, but as well as for us when we're like, okay, well, tell us about the headache. And you're like, it hurts. So,
You know,
what advice would you give to those who are going to get evaluated in preparing for their visits to talk about these headaches before they get seen?
well, I like to make it easy. I like to make it easy for the patient as well as the provider. So
Hmm.
there are three questions that you just need to ask yourself, and that will give you the high likelihood that you have migraine. Number one, pain, severe pain. Are you having severe pain that is associated with nausea? Okay, and light and sound sensitivity. So if you answer yes on those three questions, then the positive predictive value, meaning you are most likely to have migraine, that number is about 98%.
Wow. Just with
So
those 3 questions.
just with those three
Mm.
questions. And the mnemonic is PIN. Okay, so it stands for P, photophobia or severe pain, I, intensity, and N is nausea. You answer yes to all three of those, you likely have migraine.
Wowzers, wowzers. All right. Well, you make it sound so easy. That's why we are so grateful for your expertise, Dr. O'Brien. All right. So let's switch gears a little bit and let's talk about facial pain. So, a lot of times when we think about headache, people think about migraine or tension headaches, which, are very common and well known. But let's talk about facial pain. I have a lot of folks that come in that are describing, they call it a headache for lack of a better term, but that's not really what's going on. And one of the most common reasons that people come to see the neurologist for facial pain is something called trigeminal neuralgia. So let's talk a little bit about what that is and what are some of the symptoms of that.
Sure. So trigeminal neuralgia basically is pain affecting any one of the three branches of the trigeminal nerve. So I tell patients that you've got a nerve that kind of sits back in the brain and has three branches, and what connects them is the trigeminal ganglion. The first branch goes to the forehead, the second branch goes to the sinus, and the last branch goes to the jaw. So any one of those branches can be affected. And so patients may notice severe lancing pain, typically lasts anywhere between seconds to 2 minutes, that can affect any one of those three branches.
Mm.
And they can be activated by some type of stimuli, chewing, any type of movement of the face that can cause that pain.
Mm. And what are the causes of trigeminal neuralgia? Do people just get it out of the blue? Is it, telling us there's some underlying syndrome going on, or why do people get it?
So when we think about trigeminal neuralgia, we first want to rule out any secondary causes. And Dr. Williams, you being an MS specialist, we want to make sure that one of those causes isn't from a demyelinating condition like
Yeah.
multiple sclerosis. So one
Hmm.
of the things we try to do is go ahead and get imaging to take a look to see if there's any, what we call pathology or cause. So one of the common causes for trigeminal neuralgia is compression of the nerve. Okay. And so if we see that, then that's an opportunity to provide intervention to relieve that compression. So when we see that compression of the nerve, we call that sort of classical trigeminal neuralgia. But there are instances where we don't see any compression at all, and it's what we call idiopathic, meaning there isn't an underlying cause. But what's important to note, though, is that if you do have these kinds of symptoms come along, that we rule out any secondary causes, potentially like a tumor or something
Hmm.
discriminating.
Yeah, so, I think that that's important, that people recognize that if they're having that symptom, there does need to be some type of workup to make sure that we don't, see a cause that needs immediate intervention. And so
Mhm,
I think that's
mhm.
extremely important. Trigeminal neuralgia pain can be very severe. I have lots of patients like it is like crying, really, really severe pain. So how do people or what are common ways to treat it?
So there are medications that are used to treat it. Some of the best known medications are some of your anti-seizure medications.
Mhm.
And then there are what we call neuropathic or neuroleptic agents. So these are agents that work on the pain pathways to reduce it. And then again, if we do find that there is a compression, then we will typically call our friendly neurosurgeon to see if they can provide some decompression relief.
Yeah. What are other causes of facial pain?
Well, as a neurologist, I will also get consulted by a dentist. And I think
Lots of consults from our friendly
from
dentist.
our friendly dentists. So, in terms of common causes, we want to make sure that there aren't any dental reasons why patients are having facial pain. And then part of that again is because you do have nerves, and some of that nerves are involved, in the lower branch of the trigeminal nerve, as I mentioned. So we want to rule out any dental pathology. You talked a little bit about sinus headache. And I often get told by patients, oh, I don't have migraine, it's a sinus headache. And I say, okay, well, how do you treat those? Oh, I take like a sinus medicine or I take ibuprofen and it goes away. Well, it's likely migraine because you can get irritation of that second trigeminal nerve that can feel like pressure and feel like migraine, and feel like sinus headache. So a sinus headache, a true sinus headache, is if you have a sinus infection with copious fluid causing irritation to cause pain in the sinuses. And the only way to get rid of that really is by antibiotics.
Right.
So yeah,
So if you're taking your regular sinus medication and
yeah,
your headache goes away, that's probably a migraine.
it's
Now, if you
probably
got
migraine.
green
Correct.
stuff coming out your nose, that's a
Yeah,
whole
that's
different
not it.
thing.
Yeah.
Absolutely. And I think, again, it's important because these are things that, people talk about in the community. Oh, you got a sinus headache. Oh, you got
Yes.
a hungry headache or,
Yeah.
whatever. And we've given them all different types of names, but there
Yes.
are proper names that they need to be given, particularly if they are getting to the point where they interfere with daily activity, etc. So we talked a little bit about lifestyle modification, right? Which again, we talk a lot about on Brain Chat because I think it's important for people to be empowered
Yeah.
and to know that there are things that they can do oftentimes, in addition to taking medication if it's needed, to help with chronic conditions. What about, things for people that have tension headaches? So we talked a little bit about migraine. People need to get sleep. People need to, make sure that they're looking at their triggers. I often encourage people to keep a little diary for me. I know I'm old school, but I tell people to keep a little diary for me, right? Let's see if there are certain things that you're not aware of that may be triggering your headache, right? If you're in a really stressful situation, if again you miss that sleep, if you go through the perfume counter at Macy's or Nordstrom's, right? Certain smells, certain types of foods, right? After you drink 10 cups of coffee, right? So what are some of those ways that people can kind of keep track of, different symptoms they may be having? Or
Yeah.
what are some of those other things they can do, on a regular basis that can help, decrease the frequency of headaches?
Yeah. So I try to explain to patients and let them understand that, first of all, migraine is not your fault. This is not something that you have caused. It is a neurological condition that unfortunately you've inherited. Okay. So there's a hereditary component, but there's also an environmental component, as you mentioned, Dr. Williams. And so for patients with migraine, you've inherited the migraine brain. And so what that means is that you've got to be able to protect it. And the way we protect it is by living a healthy lifestyle. And as
Mm.
you mentioned, Dr. Williams, if you've noticed that you've had certain triggers, in other words, if you are drinking certain wines or certain aged cheeses, avoid that. If there are certain smells, first of all, patients with migraine tend to be osmophobic anyway, meaning they are smell sensitive.
Hmm.
Talk to whoever you work with or who you're living with to minimize the perfume or odors. Nobody in my office is allowed to wear perfume because it tends to be a trigger. So making sure you're getting adequate sleep. So I tell patients at least 6 to 7 hours, consistent sleep, staying hydrated. What I mean by that, drinking, at least 6 to 8 glasses of hydrating fluids every day, water with a salty snack, as long as you don't have high blood pressure or any contraindication to having any salt in your diet. It's also important to exercise because exercise helps increase endorphins, helps you tolerate pain better. I talked about watching the amount of caffeine that you're drinking, especially if you've noticed that that's a trigger. And then most importantly, not skipping meals. So skipping meals can be a trigger for migraine. And the thought is, fluctuations in blood sugars, yada, yada, yada. But again, what the brain likes is regularity.
The brain likes regularity. I love that. And I love that there's, so much talk now about brain health. And I
Mm-hmm.
think that that is partially because now we have more effective treatments for, neurologic conditions than we had before. So now we can focus on, okay, now that we have better ways to get you out of this pain or to help you manage that, how can we keep your brain healthy, keep your brain functioning optimally to try to prevent this from happening,
Mm-hmm.
as much as possible.
Yeah.
Are there any other headaches that you commonly see in your practice?
So I do tend to see patients with cluster headache.
Mm-hmm.
It's not very common, but as a headache specialist, I do get referrals for those, and those are pretty terrible headaches,
Mm-hmm.
otherwise known as suicide headache, because these are so excruciating. They tend to last anywhere between 30 minutes to an hour and a half. They tend to be, one-sided and have what we call autonomic features to those. So whether that's tearing, runny nose, redness of the eye, and patients just can't sit still because the pain is so severe. Those kinds of
Mm-hmm.
headaches are in the class of what we call trigeminal autonomic cephalalgias,
Mm-hmm.
rare, but something that you should definitely seek your doctor or neurologist to treat, because they can be very debilitating.
Mm-hmm.
And then we talked about the migraine, which is most common, again, because it tends to be very disabling and debilitating. I don't see a lot of tension type headache, although I will say that patients with migraine can also have tension type headache.
Mm-hmm.
So yeah, so those are, and I see a lot of occipital neuralgia.
Mm-hmm.
So pain in the back part of the head. I do see some cervicogenic headaches, so patients who have arthritis in the neck, that could be triggering head pain. So those are the most common types of headaches I see.
Mm-hmm. And one of the most common things, again, when we talk about myths in the community, is that people get scared. They say, I have a headache. My friend had a headache and she
I'm
had an aneurysm.
brain too.
She had an aneurysm, and I am just terrified that I have an aneurysm or I've got a tumor. So, what are some of the symptoms that people should be concerned about? If they have, how do you discuss this with patients if they have a headache, in terms of whether or not they would need to be worked up for an aneurysm, or whether or not it's something that needs to be observed? How do you have that conversation with folks?
Well, as neurologists, we tend to go by a lot of different paradigms. So, rule books, and one of the rule books is based on a mnemonic called Snoop, with extra P's. And so we kind of go through that again. We talked about whether or not there's systemic reasons. So, if you have a fever, but you're talking specifically about brain tumors. And so, brain tumors tend to grow slowly,
Mm-hmm.
as you know. And in patients, let's say, who have had headaches for 30 years and they're coming to me now complaining that they're having a headache, probably not a brain tumor,
Right.
especially if there's no other symptoms like numbness or weakness or balance issues. Okay.
Mm-hmm.
Where I would be concerned is if you're over the age of 50,
Mm-hmm.
never had headaches before. I say you don't have any idea what it feels like to have head pain, and then you started having headaches, whether you're over or under 50. If you have never had headaches and started having headaches, that's where I would start to be concerned. But,
Mm-hmm.
as long as these headaches are very stereotypical, meaning that they're very similar, you've had them for years and years and years, they haven't progressed, there are no focal neurological symptoms, then I'm comfortable making the diagnosis without getting any imaging. I will
Mm-hmm.
tell you that when we looked at patients who have symptoms of migraine, so if you go through and mark off to ensure that they meet criteria for migraine or even tension type headache, that brain tumors are seen in less than 3% of patients.
Mm-hmm. And I think that's reassuring. And oftentimes, what I wind up telling my patients is that if this is occurring over and over and over again with no lasting effect, that is usually a good thing, right?
Yes.
Because if you had, let's say, if you had an aneurysm, right? And sometimes people can have an aneurysm that will, have some bleeding before they have a bad event.
Mm-hmm.
That's a one or two time thing, right? So you're going to have one warning, and then the next
Yes.
one, you're going to have a big problem, but you're not going to have 10 years of similar symptoms over and over and over again that go away, and that be, the issue, or that be the cause of it. So that repetition and that similarity of symptoms often can be very reassuring, for those, even though it may be scary to you if you're dealing with the headache or dealing with the symptoms. So that's really
Absolutely.
important. So we have come to the end of our time. I know
Oh,
it went by fast. It went by fast.
I was having so
But
much fun. This was great.
I know. So we always have such great conversations, and I really appreciate the way that you educate the public and all the amazing work that you're doing at the Headache Center of Hope. So tell us, how can people find you if you're on social
Yeah.
media channels doing things, and then we'll close out this episode.
Yeah, so you can find me on Instagram. Dr. Hopi is my Instagram. I know, very, very easy. You can also find me on my website, so www.hohcincy.com. You can go on there, and there's some awesome resources there. So yeah, check me out. And I also have a Headache Center of Hope X for those of you who still use X, otherwise known as Twitter. So
Mhm.
yeah.
Awesome sauce. Well, thank you so much for your time. Thank you for lending your expertise to our Brain Chat audience. I know that it will be well received, and we appreciate everything that you do, Dr. Hope. And we're going to have you back.
Oh, thank you. My pleasure. Thank you so much for having me. Take
A-
care.
Absolutely. And thank you to our Brain Chat audience. We will see you all again, guys, in 2 weeks.